Good morning, everyone. It's Wednesday, February the 2nd. There's snow outside. I'm Dr. Stephen Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live at the Adult Simon's Family Studio. Welcome to another news and community conference with Chief Medical Officers and infectious disease specialists from across the metro and across the state of Kansas. Since last week, when we were together, COVID cases here appear to be holding. But it is no reason to let up on the gas, as both cases and hospitalizations, though better, still remain higher than any other prior surge in the pandemic, and we are not out of the woods yet. And neither are the counties in the area surrounding the Kansas City metropolitan area or throughout the state of Kansas. Over the next 45 minutes, we will hear from 15 physicians, including myself, with specifics on how the entire health system remains under great stress due to the sustained period of high transmission and a depleted workforce. We'll also spend a little time talking about how to stay safe in this winter storm, because you want to avoid a trip to the emergency rooms right now as we continue to battle COVID. Well, here's a hint. Dress warm, don't go outside, don't be on the roads if you don't have to. After we hear from our physicians, we'll open up this to reporters and to the community for questions. We ask that reporters say your name and news organizations when you ask your questions. Members of the community should put their questions into the chat feeds where you're watching. Jessica Lavelle will monitor those feeds for questions. And we've asked stations who are restreaming this to monitor their chats to share their viewer questions as well. Let's begin. We're going to start out talking really quickly for this morning about a few graphics to set up our conversation. First, here we go from the local ones from the Mid-America Regional Council. Logan's going to post those for me. As you can see, the case numbers are clearly trending down. And you can see that in the New York Times. You look at both Kansas and Missouri. I was just looking at them. They're down about 30 or 40% from our peak. But just to say, even when they're down 30 or 40%, they're still higher than at any other point of the entire pandemic. So don't get cocky. Remember, I don't want to make a Chiefs reference right now because it's too painful to me to do this. But we don't want to. Don't do the second half Chiefs thing. Don't get real comfortable and then and think you can violate all the rules, because it doesn't work like that. Because then the cases can go right back up. The second thing is, we know that hospitalizations have appeared to crest in both Kansas and Missouri and are just starting to trend down. We really don't want those numbers to go back up. And the number of deaths is also starting to trend down, which we're really happy about. We've had a lot of deaths, and I'm going to turn to Hawkeye for just a minute. Hawkeye, man, this has been kind of a bad month for us.
Yeah, it's been really bad as far as deaths go. We had our last inpatient death was actually the last 24 hours, but even in January, we had like 46 or 47 deaths in January from COVID-19, We know that when sometimes patients come in, they are incidentally found to have COVID-19, whether it's if it's coming in for a car wreck or trauma like that. But these deaths that we described, these deaths are from COVID-19. And so 45 in the month of January or 46 in the month of January is really a lot.
Heart failure, old age,
Yep.
COPD, cancer, those are supposed to be our leading cause of death, not COVID-19. That is a totally preventable cause of death. Let's bring in Dr. Richard Watson, the co-founder of Motient, the company which created the Mission Control app. That's been a really important app for folks trying to move patients around when we can't get from especially a lower acuity hospital to a higher acuity hospital. It's the app the Kansas Department of Health and the Environment uses to connect rural hospitals when trying to transfer those patients. Dr. Watson, talk to us. Show us the latest information you have depicting the pressure on rural hospitals to transfer. Does it appear to be easing? What's the news out there?
Yeah, great, and thanks. I think transfers are a good indicator of how the system is working from the bottom up, and certainly the sending facilities feel the relief on the pressure before the receiving facilities. But if you put up the graphic this morning, we're still following the trend on the left. We see the slope is downward and promising. Again, when we see this kind of a change, we know that there is significance to it and that it is a lasting change. I think everybody's been a little bit worried about BA2, the subvariant of Omicron, and what that might mean. Currently, we see no indication that genetic shift is causing any sort of problem in the system. We do think it's active in the state, and we do think it is at least a major, if not a very major part of what we're seeing in Omicron. But at this point, it doesn't look like it's going to be a real player at this time. The graph on the right teases out a little bit on the death rate while waiting for transfers. And you see that the bar graph, we had a peak in January, which we reported here initially, and that was the alarm we sounded at that point that we were seeing this high level. Since that time, we've been on a steady decrease downward week by week, and I think it's threefold. Easing the disease pressure, no doubt, also opening up the VA beds, very helpful to what happened in the system. And then thirdly, we just know of individual cases of receiving hospitals making a concerted effort to turn patients quickly and pull new patients in to their systems. So very thankful for all of those things. I think we're seeing in the trends that we still have to come off about 20 to 30% of current case rate to really move that capacity index down. We've been riding at 3, which is no capacity, for several months now. And in the last month, we've seen actually gone from 3 to 2.9 to 2.8. We really need to be about 2.5, 2.6 to see the system open up.
So we're seeing some good information then, though, that suggests that we are having a better trend, although some of those challenges, when I was looking at your graph, they're still at the highest point they've been throughout the pandemic. Is that what your sense is?
Yeah, I think everybody's kind of gotten numb to COVID news, and hospitals know this is their job, and day in and day out, they've got to take care of very sick people, COVID or not COVID. And so we all get really used to making it work, but the public just needs to continue to realize that this is not gone, that we're still dealing with it. There's still congestion in the hospital, whether you have COVID or not. So anything anyone can do to help continue to take it out of the community, really appreciated.
Yeah, thank you. And it is good to know that people are being able to get to a better level of care where they need, but it's still too long a wait overall, and we're still, I know, challenged by it. And when you sit back and look at it, I think you're right. Folks are numb to this pandemic, and they're also a little nutty from the pandemic. So what does that make us if we put numb and nuts together, I wonder? That's not good. Hawk,
Yeah.
let's talk a little bit about our numbers. How are we today?
Yeah. Numbers are trending down, Steve. So I think we are happy about that. I think we've seen the last couple days now that numbers have trended down. So 95 active infections, 26 of those in the ICU, 14 on the ventilator, still 91 in that additional recovery period, but a total of 186. And I think it's good that we've dipped below that 100 active infections. I think that is good news. I think that goes to what you said a couple days ago. Looking out weeks or a couple months, the spring and summer should be much better for us. I think we need to continue to advocate for vaccination. But overall, the numbers are better. I think hopefully we will continue to see that trend. And would just like to correct, we actually had 45 deaths, or 54 deaths in January. So more than I had said.
We're allowed to make number inversions now at this point of the pandemic. But right, we've had 54 deaths, which is way too many, because remember, all of those deaths were preventable deaths. Right? These were not necessary deaths. These were COVID deaths. All right. Well, let's start going to our chief medical officers across the region and see what things are like. I'm going to start with, this is Hawk and I have talked, we're going to start with Chief Medical Officer at Advent Health, Dr. Lisa Hayes. Lisa, how are things?
Good morning, Dr. Stites. I have to say things are trending down a little bit here at Advent Health Shawnee Mission. Today, we have 43 active infections and 21 that have cleared their infections. That's a total of 64 patients. Our peak was on January 11th when we had 95 total patients. So we're down 33% from mid-January. So that's a nice trend, and we're down 23% from last week. We have had 26 deaths in January. And I know one in the last 24 hours as well. So we are continuing to see people passing away from this disease. It's like you said, not time to take our foot off the gas. We continue to have difficulty with people holding in the ER, although the wait time for holding has gone down. We have 11 people holding in the ER this morning. Still having employees out, but that number is trending down as well. We have 76 employees out, and 67 of those are clinical. That's approximately 2% of our employee population. And we have been able to resume elective procedures And so that's a good note as well.
Yeah, that is good news. We restarted that full bore this week, so we were happy about that. But having employees out still limits you, right? Then I think it probably affects us. And at Liberty, Dr. Raghu Adiga, Chief Medical Officer there. How are your numbers? And one of our also ID colleagues.
Thank you, Steve. I remain optimistic. I should say cautiously optimistic at Liberty and for our Northland. I'll start with the good news. And we are also currently down in terms of inpatients with COVID. We are down to 32 with 6 in ICU, 5 on ventilators. That's a 25% drop from last week and 50% drop from our peak a couple of weeks ago. We actually peaked a little bit ahead of most of the Kansas City area. And less staff are out due to COVID, and we are starting to scale back up our delayed procedures and all that. So those are the good news. But here is the thing that gives me a reason to be very cautious about it. We also lost a lot of people, and we continue to lose a lot of people to COVID. We lost 36 people in the month of January. That's a lot for us. And even in the last week, we had about 4 deaths. And the staffing shortages and supply chain issues have not gone away. They're still there. And Northland's COVID incidence is still extremely high. This is higher than the Delta peak. Clay County had 935 for 100,000. That's extremely high. And same with Platte County, 520 for 100,000. So the pressure from the community is still there. So this is not the time, as you said, to let down our guard. If we keep it going, I think we'll have a better spring and summer, and we just need to stay with it.
I think that's right, and we know. But when you started out saying you had some good news, I thought you were going to tell us the sun was out and it didn't snow up in the Northland. But I guess that wasn't quite true.
Sun might be out.
All right, Dr. Elizabeth Long, Chief Medical Officer at Olathe Health. How are you?
Well, thank you. Good morning, everybody. Here at Olathe, I feel like we've had a small miracle in that our high was 57 COVID positive patients. That was around January 11th, and we are down to 13 today. And 2 of those are in the ICU on the vent. And so that has given us a chance to take a deep breath. I echo everybody's thought process in that we can see how quickly this turns. It can go up and it can go down very, very quickly. And our medical systems have to flex accordingly. We have restarted all procedures as well. And so it is something that continues to undulate up and down. And anything we can do to just continue this great trend is exactly what we need to be doing. Thank you.
Yeah, I think that's exactly right, and we do have to be careful, otherwise we'll end up being back in trouble again. Dr. James Stewart, Chief Medical Officer at North Kansas City. How are you this morning?
I'm doing well, thank you. Good morning, everyone. We have currently 77 acute patients with 46 that are in the recovery phase for a total of 123. 16 are in the ICU and 14 of those are on ventilators. Our peak was January 15th, when we had a total of 145. So we've come down from there, but we've really plateaued in the last week and stayed at about this level within a few patients. January was a bad month for us in terms of deaths as well. We had 65 deaths in January. A previous monthly high for death rate was 47 at the beginning of the pandemic. So it is still real. We still have a lot of patients, and it's better, but we want it to continue to improve.
It's interesting to see some people go down by 60 or 70% and some down by about 10%. We're glad we finally got from our high of 200 and oh gosh, I'm going to say it wrong. I want to say 24 down to 186 or so to 188 today. Yeah. So that's good news. But I tell you, we stuttered right around that 200 to 220 plateau for almost 2 weeks before this 186 represents, I think, really good news. Mark Steele, Chief Clinical Officer at University Health. How are you?
Doing well, Steve. Thanks. And good morning, everyone. So we also continue to see some improvement in our numbers here at University Health. We had 24 COVID discharges yesterday. So today we're sitting at 87 total patients for our hospitals. Our high was back on January 19th, where we had 137. So that's about a 35% decrease. 48 of the 87 have active infections and 39 are recovering. We currently have 9 in the ICU and 4 on ventilators. Like the others, we had our record high of deaths, unfortunately, in January. We had 36, and our prior high was in August, which was 22. And unfortunately, we continue to see deaths. We've had 3 so far in the last 2 days. We're only holding 5 patients in the ED this morning for admission, which is an improvement for us. Like the others, our staffing remains tight, but our number of employees currently out related to COVID is now less than 100 and does continue to trend in a better direction. Our demand for COVID testing has eased some, and our test positivity rate, we're seeing a drop in that. It was nearly 40% at the peak of Omicron, but now it's dropped to 23%. So that's also a bit of a positive sign.
Yeah, I think that's a really important sign. There still are a lot of positives out there, so we got to be careful that we don't get too comfortable with that. Dr. Ahmad Batrash, Chief of Staff at the Kansas City Veterans Administration Hospital. How are things for you all today?
Good morning, Steve. We saw our peak last week, actually, of the inpatients. We reached 38 inpatient total for COVID that were for a couple of days, actually, and hovered around that number for quite some time. This week, we're starting to see some decline, but seems like our peak was reached a little bit later than some of you for hospitalization. So we have today 29 active patients, and 5 of them are in the ICU, 1 in the vent, and we have also 2 convalescent that cleared the acute infection. As far as the outpatient numbers, also trending down. We peaked on January 12th at about 650 active infections out in the community and like outpatient, and we are down to 404 now. So that's a welcome trend. Same trend we're seeing with the employees also. Being out due to COVID. Today we have only 60 total out due to COVID. So again, welcome trend. We still have 3 in the ICU who are non-veterans through the 4th mission that we helped with the rural Kansas transfers.
And let's just say to you guys and to all the VAs, thank you. As we heard from Dr. Watson early on, that really did make a difference to open up those beds to non-veterans. So thanks for what you've done. You know, because I'm not aware.
Yeah,
it was a big deal, man. I skipped over and I apologize because sometimes I'm illiterate. Dr. William Gilberts II is the Chief Medical Officer representing St. Luke's Health System today. Okay, well, he's not here, so I didn't skip over him. Darn it. All right. Dr. Jennifer Scripture is an infectious disease physician at LMH Health and Deputy Public Health Officer for Douglas County. Jen, how are things?
Hey, Stites, thanks. I think we're doing better. I think we've vacillated between the low teens. Our high was 26. Today we have 15 active, 7 recovering, 5 in the ICU. 1 is holding in the ED, 1 on vent and several on vapotherm. We had over 80 employees out at one point, and now we have just over 40. So that's that's my big number for today that tells me how things are going locally. Still seeing over 20% positive for in-house testing. Still watching surgeries daily. They're capped, but we're looking at those daily. And the same theme as everyone else. We had over 20% of our deaths throughout the pandemic in the past month, including 2 in the last 48 hours. And again, our thoughts are with the family, continuing to focus on, excellent patient care, keeping our employees and our patients safe.
Yeah, that I think the stories about how Omicron isn't so bad. Right. It's not so bad unless you really have it and you're in the ICU. Then you're going to think it's really bad. And then families who watch their loved ones die. I was in a conversation yesterday. I follow a lot of lung transplant patients here, work closely with Barnes for that. And so at any rate, I had a conversation with their director of the medical director of lung transplant there. He's saying they've had so many deaths right now from COVID-19, and they're not sure about I said, well, gosh, is that just because so many transplants are getting Omicron? He's like, Maybe that's part of it, but it feels like it's a problem both in the denominator and the numerator, that somehow Omicron is worse than what we were originally represented. And we're seeing that across the United States. The rate of death in the U.S. is the highest of any of the industrialized countries. All that is Omicron is not Omicron, so be careful what you ask for. Jackie Hyland, Chief Medical Officer at St. Francis in Topeka.
Good morning. Thank you, Dr. Stites. So our good news here on the St. Francis campus is we only have 19 associates isolating this morning, and that's the lowest since the 29th of December. That's our good news. We continue to we're plateauing. We have 40 positive inpatients today, 3 are recovered. We continue to be over capacity in our ICU and on our medical floors. We are starting to really assess the status of those patients who are on the medical floors. There are some very sick patients on some very high flow oxygen that the nurses are caring for on the medical floors. And so that's just been a big concern for us as we're trying to manage the acuity of patients that come through. We continue to hold patients in our ER. And then on the mortality side, since last Wednesday, we have seen 7 deaths, so 1 COVID-related death every day. Before the pandemic, we had about 12 to 14 deaths total in the hospital. So this is something that not only affects the families, and our hearts do go out to the families, this affects staff. And the other, I think, pandemic, and Dr. Hayes, I think, touched on this a few calls ago, and the health system does a beautiful job addressing this on the physician calls, is burnout. Burnout for physicians, burnout for the nursing team. On the medical floors, when they're at 1 to 5 patients and they have very sick patients, and the patient inadvertently takes off their BiPAP or their Vapotherm, they can deteriorate incredibly quickly. And it takes a long time to get your PPE on, to get into the room, to make sure that that patient has what they need. So we're not out of this. I think the public needs to know that, most of the time, it probably is just a little cold. But there is a significant amount of patients who enter the hospital who, unfortunately, may not be able to return to their family. So, I just implore, I love what you say, Dr. Stites, just follow the rules of infection control, and we have a treatment, we have a way out of this pandemic, and that's getting your vaccine. That's one way to ensure you return home if you enter the hospital.
Yeah, when I say thank you, and when I love to say live long and prosper because I'm a Trekkie, I really mean live long and prosper. Get your vaccine so you can live long and prosper. All right, Dr. Kevin Dishman, Chief Medical Officer at Stormont Vail. How are you?
Morning, Steve. I wish I had better news for you, but I'm going to be echoing what Dr. Hyland said. We are still either at our peak or hopefully at our plateau. One of the reasons for that is we are still seeing an abundant number of transfers from the rural areas. And our colleagues in the rural areas have been doing just a huge, amazing job of caring for patients that they just don't have the opportunity to transfer. And for all of us that have worked in a rural setting, we know that for them, there's not a day off. And so being able to take those patients and help with caring for patients in the rural areas has been one of the keys that we've been working on through this pandemic. Through flexibility of our staff, we were able to get almost an additional 30 beds open on Monday, and those were instantly filled largely with COVID transfers. Our COVID numbers continue to rise. We're up almost over 80 today. 12 of those are in the ICU, and we've experienced the same things you've heard this morning. I believe that we're still seeing the peak in the rural areas of Kansas, and hopefully are at our peak right now, Steve.
Yeah, I hope you're at your peak too, man. We need to have that whole good news being coming all across Kansas, and thanks especially for the way y'all, and I know St. Francis tries to do it and others try to do this, and we're going to hear from Sam Antonios in just a moment, but that bit about helping out rural Kansas is a really big deal, and we've been so full, it's been difficult to accept the transfers. We're starting to open that up a little bit because we're a little less, not as COVID, we've got a few less patients, but it's still really hard. So let me turn then to Dr. Sam Antonios, who's the Chief Clinical Officer for Ascension Via Christi in Wichita. Sam, how are you guys today? Did you get a lot of snow?
Good morning. We do have snow. Snow is on the ground. It's a pretty cold day today here in Wichita. So good morning, everybody. And we're seeing a little bit of a similar story, a little bit of improvement. Looking at our numbers today, we're at 160 total patients at the system level. 140 of those are in the Wichita area. The rest are throughout our health system in the whole state. We've got actually quite a few patients in the ICU. We've got around 45 patients in the ICU and 10 are on the ventilator. So still a lot of burden of illness within our hospitals, even though it's better than last week. It's about 25% better than last week, but we're still at a pretty high mark. In fact, we're probably close to our last winter peak, which means that we still are challenged with being able to take care of the patients. Obviously, we assess every day, hour by hour, the ability to help the rural hospitals. We want to be there for them. That's why we're here. And we've been able to help a little bit. And we've been able to receive some patients, but definitely not at the degree that we would hope to be or want to. So I'm grateful for the staff. Everybody has commented about what the staff has been going through. And our staff has been witnessing a lot of death, which takes a toll on people, and we can't ignore that. So shout out to our staff who's been doing a heroic job throughout this, and I'm hoping that there will be more acknowledgement of the challenges that the healthcare industry as a whole is going through today when it comes to its workforce. We need holistic and systematic solutions for the workforce as a whole, federally and at the state level. Thanks, Dr. Stites.
Yeah, no, thank you, and thanks for all you've done to continue to help. We work with KDHE and the other Sam, and man, I tell you, you're right, and I appreciate everybody. I think has kind of made reference to the impact on the staff and the mental health and where our teams are. This is a difficult time, and probably the most. I think I may be the old guy here, but lived through the HIV era, and this is a really challenging time. And even reference to the HIV, there's more folks in it, and the rancor that our staff all of our staffs have had to endure, and about how they're being treated by. Unfortunately, it's by some patients and by some of the public. They've gone from heroes to being villainized, and that's a tough thing, right? That's a really tough thing for our staff, and I think has had profound impact on their mental health. Hey, let's turn to reporters and see what questions that may be on the line from any news media organizations. All right, Jess, what do you got?
I do have a question. I do. From
Go.
Jake. He has a question, and he is wondering, with the case numbers and hospitalizations on the decline, is there any concern about another spike in cases following last week's get-togethers in the Chiefs game? And might people want to change some of their behaviors due to that? That's Jake from KCUR.
Yeah, you bet. So, Hawkeye, Chiefs game, it was a little depressing in that second half. Yeah. Maybe it was more than a little depressing. But, I think the key is that the rules of infection control don't change because the Kansas City Chiefs played football, right? The rules are still the rules. And if you want to see the numbers rise, break all the rules, get into crowds, indoors, take your masks off and party, because there's still going to be some COVID transmission out there.
Yeah, I think if you look at the whole picture from Thanksgiving until now, I think again, the Chiefs game itself, most people are outside. We have continued to say that is quite low risk compared to some indoor gatherings. But I think overall, if you're taking the big picture of the Delta period, the Omicron period from Thanksgiving until now, I think that is going to be a fairly insignificant amount of spread that is going to increase the cases overall.
And let's hit on this next question because it was raised a little bit. We talked a little about the stealth. I think Dr. Watson mentioned that about the stealth Omicron variant, because I think one of the insider discussion, if you will, has been, and I'm going to turn to our panel here in just a minute, has been whether or not we've seen so much Omicron transmission and so many people have had it, because when we quote you case numbers, it's projected that the numbers of people who are actually infected are 2 to 4 times higher than that. That so many people have now had COVID and so many people have been vaccinated and a lot of people have both. We're going to have a high rate of immunity, which is going to protect us from some further spread and maybe even the next variant. Is that truth or is that fiction? I'm going to first turn to Dr. Scrimshire since he's sort of the public health officer here. What do you think about that, Jen? Were you here? Did you hear my question there?
Yeah, yes. I did. That's my hope. But it was also my hope after the Delta surge. So I was planning to have a pretty chill winter, honestly. And I got burned on that crystal ball prediction. So there's always the chance, if there's ongoing circulation of the virus in the community, for it to continue to mutate and continue to throw out variants like Omicron. So I don't want to get too comfortable. And again, like Topeka, Lawrence, Douglas County is a bit behind Kansas City. We still have a really high number of active infections in our county. So I'm not quite done with this yet and looking to the next surge. But it is my hope that we have a period at least where we have a lower level of infections, and hopefully our staff and our community members can recover mentally and physically to prepare for what's next.
I'm going to hope it's going to be a better spring and summer. I don't know, Dr. Dishman, what are your thoughts?
Well, Steve, I think that as we look for any port in a storm, so to speak, anything that increases our ability to fight this virus is going to be a positive thing. I don't think there's any way that anyone should think we should come off of vaccination and come off of, as Dr. Hyland said, staying with the things we know that work. Trying to stay out of crowds as much, even though the risk may be small, ensuring that we wear our masks and that we get vaccinated. It's really about going back to what we've been saying throughout this entire pandemic. And as you iterated this morning, these getting infected with COVID is and having to go to the hospital, that's preventable.
Yeah. And Dr. Antonio's thoughts?
Yeah, well, actually, it's a very good question. And I think it's on the minds of a lot of people. Well, is there now enough after this Omicron wave? A lot of people got sick, so maybe now a lot of people are immune. And the reality is, theoretically, that could happen. The reality is we don't know because we still don't have the data. However, I would like to remind everybody a couple of things. Number one, we have seen Omicron itself evade immunity. And so there's really, we don't know if another variant could again attempt or succeed at evading some immunity. That's already happened. The other thing is we know that immunity wanes over time. And every other study I've seen where it's even, either looking at clinical picture or looking at some antibody studies, you'll always see these graphs of over time decline in the immunity until a booster occurs. And today, what probably I would say it worries me the most about that would basically punch holes in the theory that everybody's going to be immune is the rate of boosters in the United States. I saw this morning a report, and I haven't really had a chance to dig deep into it, but that the United States has the lowest booster rate amongst all the developed nations. So that is a reason for concern because we know over time we're going to lose our immunity. And so it's a matter of trying to keep that up with immunization and boosters. So we're hopeful, but we'll have to wait and see if those hopes are going to materialize.
Yeah, you got to believe that low booster rate and that higher death and that higher hospitalization rate probably go hand in hand. Jess, other questions?
Yes. Cody from Channel 9 has a question, wanting to know, do we think that we have hit the peak of Omicron infections? And if so, what will that mean for area hospitals?
All right, Dr. Adiga, what do you think? You're as an infectious disease expert. Are we over the peak? Are we over the hump for Omicron?
Well, I think we have hit the peak, but that doesn't mean, you remember there are two sides to the peak. There's an upward wave and the downward. So that's going to take a while. It's not a sudden drop off. So, and a lot of hospitals you heard are plateauing in their numbers. So by the time we come down from the peak, it may take several weeks. So we're not completely out of the woods, but things will get better. And we just still need to continue to deal with our existing issues, staffing problems, as I mentioned, as well as, the supply chain issues, and all those are going to be there. And there is a demand for healthcare that has been put off. We need to still continue to serve these patients who've been waiting for their surgeries. So there is still a lot of other illness that's out there that we need to continue to, care for. So I'm hopeful, but hope alone is, not a good strategy. We need to continue to work on other things.
That's right. It's got to be combined with faith, hope, and science, because the science has got to really bring us home. And one of the things I'm concerned about is that we could see yet another rise if we're not careful. I think one of our earlier folks we were talking about, man, if you take away the rules of infection control, don't think that everybody's really got that much host immunity yet, especially now that the stealth variant is out there. And Dr. Watson, any thought about whether it's, or Jen or anybody actually, about wastewater testing? I don't think we're doing, that I'm aware of, genomic sequencing yet to look for the stealth variant versus the standard Omicron variant, and whether or not that could cause a second peak for us, because there's reports that the stealth variant may be even more transmissible. Thoughts, Hawk?
I do, but I'll kind of save them for the end.
Okay.
About all that with transmission and Omicron and stealth Omicron and moving on from there. So, yeah, we'll let our guests speak.
You bet. Anybody want to take that one on? Dr. Watson, thoughts?
Well, I think that by the time we start hearing cases nationwide of a stealth variant, it probably means that it's already fairly widely dispersed, and I think we're counting on that. I think the thing I've been amazed with, that in households even where people have tested positive, multiple people have tested positive, we still have people who test negative with no background immunity. So my concern is, and I know there have been reports that the test is not picking up some of the Omicron cases, maybe as high as 30%. And I do think that is occurring, and it gives us all pause to understand the virus changes enough. And certainly our testing, our boosters, all of these things have to change as well. And as a society, we have to realize this is an evolving story, and it isn't a one and done deal. We've got to treat this eventually like a flu bug that has a seasonal aspect, that has a background immunity aspect, that has the need for continued boosters and vaccination. It's a virus, and it's going to behave like a virus. The difference is no one had immunity, so everyone will have to have experience with the virus before we get to a place of a different day here.
Yeah, and I think that point is, this thing with the boosters is really important. And again, in the transplant population, if somebody got their influenza vaccine, say in September, and we would often have we had a bad year or whatever, then we were telling them to get their booster for influenza. We said, go get another shot, because you need a boost come February and March if the influenza pandemic is going on, or the influenza outbreak is going on. And now what we're saying here is, gosh, every 6 months, you kind of needed a booster so far. So hopefully we won't continue that rate, but it may play out like that. I think there was another person who wanted to raise a point. Go ahead. Dr. Steele.
Hey, yeah. Hey, Steve. Yeah. So this is Mark Steele at the University of Health. I wanted to pick up on the booster topic and what Dr. Antonios talked about, and how important getting the boosters is. There's data out from the Omicron surge that if those who are unvaccinated compared to those who are fully vaccinated and boosted, the unvaccinated are 23 times more likely to end up in the hospital, and also 68 times more likely to die. So those are really powerful statistics. The key there is the boosted part. So the boosting really improves your chances of not ending up in the hospital, and also not ending up dying.
I just say on our own data, we've looked at that exact point and found exactly that same story, that, clearly the unvaccinated are most at risk. The next category is the vaccinated who aren't boosted. And then the people who are boosted and vaccinated, they're just not in the ICU, right? They're just not landing in the ICU, and they're just not on ventilators unless they have like an organ transplant and they don't have a good immune system. I mean, then there's one or two, but even like right now, out of all of our ICU folks, only one of them is fully vaccinated and boosted, and they have an underlying autoimmune process. So it's the story is the same one throughout this pandemic. Jess, other questions?
Yeah, I'd like to get to a few viewer questions, but quick follow-up from Cody is just overall, what do you want people to keep in mind as we continue to push through this pandemic?
You know, let's turn out to our panel. Dr. Hayes, what would you say to folks? What do you want them to keep in mind?
You know, definitely want to continue to encourage everyone to get vaccinated, continue to socially isolate if you're ill, wear your mask out in public. But also I want everyone to think about giving grace to your healthcare workers. When we're talking about, are we through the peak? I think we're through the peak of COVID in our hospital census, but I think we're still going to see the ramifications long-term to our healthcare workers, people leaving the profession. We're going to continue to have difficulty hiring nurses, physicians, healthcare workers in general. So just continue to keep those people in your thoughts and be kind.
Yeah, be kind. Dr. Highland, advice.
I'll just echo what Dr. Hayes just said. Good infection control practices. I think that protects you from a whole lot of things. And I think we're seeing that with influenza. You know, I mean, physical distancing, masks, and vaccinations work.
Yeah, the rules of infection prevention and control, where do they go? They go with you, wherever you go. Jill.
Dr. Stites?
Yeah, sorry. Yes, please.
I just wanted to relate a patient story really quickly.
Please.
In that I was just seeing a patient in clinic on Monday, and she said that they had had a family gathering and everybody in the family got COVID and they lost 3 family members. And so just kind of putting that out there that it's a gamble. There's some serious consequences. And I think if anything, we're wanting to educate everybody about what those possibilities are so that everybody can take a look at what their personal views are and their actions are and how that affects people that are very close to them and their own family members. So they were having 3 funerals in a very short period of time based on one family gathering. And that really just hit home for me.
That does hit home. I agree. That's tough. Jess?
So we're going to get to a few community questions. Susan says she's happy to see that these cases are going down, but what's the theory as to why they're going down? She lives in Raymore, where there's a 40% positivity rate. She barely sees people with masks on. So she's just wanting to know what is with the decline.
All right, Dr. Stewart, I'm going to pick on you. What do you think? Why are we seeing the decline even when the measures of public health aren't always enforced or followed?
I think the problem is that so many people have gotten it that the virus is running out of people who don't have immunity. And whether that will be sustained or not, it's difficult to tell. I think that, in our case, we're down from our peak 2.5 weeks ago. But if we look back a year ago, the previous peak last January, that's right where we are now. So it may be down, but it's not over.
Yeah, down but not out is that. And Dr. Batrash at the VA, you have done a great job of tracking outpatient numbers. You've relayed those on the chief medical officer call. And what's your sense? Why are the numbers down? And are we going to keep seeing them go down?
Yeah, I agree. I mean, I think if we're talking about numbers down for this particular mutant because of immunity, because of those still getting vaccinated and boosted, it's going to increase in a little bit. Maybe some people are wearing masks as well. Some people are avoiding, indoor gatherings and stuff like that. So all these factors play a role in any time we have a peak that we will see some decline at the end. But the fear is, and what's been seen is that mutants are developing, and they're developing fairly, quickly. We're still going through the Greek alphabet, right? And that's very unfortunate. But at some point, there's going to be a mutant that is going to evade the immunity that was created. And then the other piece is the immunity, as mentioned, does not last long. So so the question is how long and when are we going to see the next peak? And that's really the fear.
Anything?
Yeah, I just like to, these are very good points. Just as you said, things are improving. We hope that in a couple months, spring, summer, it will be much better than it is now. I do believe that it will be. Just a couple points brought up by our guests that I'd like to kind of comment on. Dr. Steele was talking about how more evidence for vaccination and the help and the benefits of that. That is absolutely true. There continues to be more data supporting vaccination, even vaccination after infection. So those 3 doses are very important for giving you protection. Protection against what? Not infection, but giving you protection against disease. And that is really what we are all hoping for. We are hoping that you have protection against disease so that you aren't coming to the hospital, aren't having to seek medical assistance. So you are not having long COVID. And we know the vaccine helps all of those. So that if you do get a case of COVID-19, it is a mild case and you can get back to your regular daily routine. And that can happen with vaccination. Your chances of that happening is much higher with vaccination than without. So there is good data now supporting, especially those 3 doses, especially that booster, as we heard Dr. Steele talk about. Also immunity. I think we should talk about immunity just briefly. What kind of immunity are we talking about? We know, as Dr. Antonio has talked about, Omicron can evade immunity. What kind of immunity is that? That is our antibodies. And this will happen again and again. This is because the spike protein has changed. So our antibodies really aren't neutralizing at that point. It's evading our antibody immunity, causing infection. But infection is not necessarily what we have concerns about. Cases are not necessarily what we have concern about. What we have concern about is that disease that brings you to the hospital, that brings you to the ICU. But we know vaccination can help prevent even the vaccinations that we have. And this is a good thing. Since the advent of the vaccination era in COVID-19, we have seen that our current vaccines, if done correctly and kept up to date, will protect you and reduce your risk of going to the hospital, the ICU, and being put on a ventilator. If you can stay up to date with your vaccinations, that is going to help. We know that from the early South African data that those T-cell immune responses from the vaccine continue to work, and that is what is protecting you from going to the hospital and going to the ICU. So it is extremely important to continue to advocate for vaccination. Even if you've had COVID-19, it is very important to get those 2 doses of mRNA vaccine. We have continued data supporting that. This is what will protect us down the road. We know that some of the vaccine companies are maybe pivoting to an Omicron-specific spike vaccine, but to that end, we also know that the current vaccines, if you are up to date, meaning you have that booster, you have those T-cell responses to protect you against those worst cases of disease. So it is important that we continue to do that. We do know and understand that other variants will probably come through. We'll be able to evade some of our antibody responses so that we have infection. But really, it is mostly about the disease state that we are concerned about, so that if you do get a case, it is mild, so that you have a lower risk of going to the hospital and going to the ICU. And by continuing to vaccinate and stay up to date with those boosters, you will reduce your risk of having to go to the hospital. And that is really what we are concerned about. It's just the nature of viruses to be able to find that vacuum of people that are susceptible, find that space, and displace other viral variants. And we have seen this happen now since about April of 2020. We will probably continue to see it, but what we really want to do is protect you and your family from having to come to the hospital or even seeking medical attention. And the way that we can continue to do that is with our vaccines.
Jess.
Dr. Stites, I'd like to at least get these last 2 questions in from our viewers. Stephen is curious, is it getting easier for local hospitals to get the new antiviral treatment? And also, are we concerned, Donna wants to know about a late flu surge this year?
All right, let's start with, can we get antiviral treatments? Dr. Freelove, how are things in Topeka? Did I just do that again? I did that last month. I did that in the last month, Dr. Dishman. I'm sorry. Why do I do that? I don't know. I think the beard makes me think of Freelove. I don't know how. I don't know what the combination is, but whatever it is. But Dr. Dishman, sorry.
You know, I'm actually honored by that. Mistaken for Dr. Freelove. What a compliment. You know,
We lost you. Did you hit mute? We still don't hear you.
There we go.
There you go.
All right, thanks. We're seeing a very limited supply of those drugs. I think the entire community had about 60 doses available. And so I'd be interested in the experience of my other colleagues, and Jackie, we're very limited in our ability to prescribe those drugs. They are effective. They do work. But we're just not getting them. And the rural hospitals that Dr. Hyland and I work so hard to help, they're not seeing that at all. It's just not available.
Dr. Hayes, how about from Advent?
Yeah, we have been receiving a supply of the sotrovimab, but it feels like we're living week by week. But I really just wanted to give a shout out to our nursing director for our infusion center, who had the foresight to call everyone who was scheduled to come in today and have them come in yesterday and flexed up in her nursing. So we were able to do 20 infusions yesterday where we typically do 4 to 8. So I just really wanted to say how much we appreciate that.
Yep. I'm sure the Kansas City Public street crews helped are happy too. Mark, Steele, how are things on the Missouri side with things like sotrovimab, Paxlovid?
Well, I mean, there is some limitation, although we do have some supplies, although not large quantities. So we do have sotrovimab and Paxlovid, and the uptake for that has not been terrific. In particular, some of the oral agents. I think there's because of some of the contraindications and drug interactions. And so there's some complexity to getting those distributed. And but we do have supplies, but not like we had with the other monoclonal antibodies.
And Dr. Batrash, how about through the VA for our veterans? Supply of sotrovimab, Paxlovid, and the like.
Yeah, we do have some supplies, yet limited, but the problem is catching the patients in the right time. The 5 days is very limiting as far as the oral antivirals. So we need to catch them within 5 days of the start of the symptoms. So that's an issue. And as mentioned, some patients don't qualify just because of the other drug-drug interactions and things like that. So it has not picked up as we expected, I want to say, but we do have some supplies, yet limited.
And I remember at the beginning of the pandemic, it was hard to use all the monoclonals. It just didn't be part of the system, and everybody had to get their infusion centers going and get people educated. My guess is that in the long run, if we have another bad surge, Paxlovid's going to come and fly off the shelf, and certainly easier to use in many ways than sotrovimab. All right, Jess, what was that last question?
Just about a concern about a late flu surge. Where are we at with the flu?
Late flu surge. All right. Let's see what we think. And I'm going to turn to Dr. Adiga. What do you think about the late flu surge?
It's certainly possible, especially if people let their guards down because the COVID is coming down, and the indoor gatherings start increasing in numbers in the next month or two. It's certainly possible because people have not been vaccinated for flu as much, and there is always a potential for antigen mismatch, and so that's it's possible. Hopefully not as bad as before, because there is still some infection control thoughts in people's minds from what we've been preaching all along.
I sure hope so. Dr. Stewart, final thoughts around the flu epidemic. That would be a difficult thing to pile on top of this.
Yes, it would. And, last year we virtually saw no flu because everybody was scared of COVID, and they're both viruses that spread the same way. So this year we're seeing some flu, not as much as a normal flu season, but hopefully if everybody continues to mask and avoid crowds, we can avoid the flu this season as well.
All right, Dr. Scrimshire, I have my own question I want to ask you. Here we go. Yesterday, the Pfizer is talking about the 2-drug regimen for children, 0 to 5, but it didn't really look good on the 2-drug regimen, but the FDA may be saying, let's go ahead and prove it. What do you think?
I think some of those decisions are, they don't always match up with what our personal opinions are, but stepping back and looking at the greater good or what's most important to the nation at the time is really important for me, as opposed to, just drilling down on these minutiae of data. So I think it was probably a question of some is better than more, some is better than less, or some is better than none. And we can add that third dose on later if we want to. That's my assumption, but I wasn't asked to attend that meeting.
I know. Well, that's my guess is they're thinking the third dose data is going to look good. Okay, Jess, you wanted to sneak in another question. This is your last moment. Go.
Okay, so Donna wants to know if you could just update us on how we have been communicating with Kansas legislators regarding Senate Bill 381.
All right. Well, Dr. Antonios and I could tackle that one together. Our simple belief is that if you single out two drugs, really ivermectin and hydroxychloroquine, for special protection in the pandemic, it's just hard to justify that in my mind when you already can go off-label for different prescription medications. You can get hydroxychloroquine and ivermectin, and removing all the legal protections and other things for patients around that, you shift the risk for decision-making away from those who are most trained, pharmacists and physicians, in the era of this general area of prescribing medication. You shift that risk over to the patient and say, now you have to understand all the knowledge. And I think that's not the right risk, the risk shift. Because if somebody really wants Paxlovid and hydroxychloroquine, I don't recommend it, and our health system generally doesn't fill it for COVID-19. But that's because we've looked at the data and don't think that it's really a true indication. But you can still get it. And we have prescribers who may write it, and I think the key is that that we don't need special legal protections or special bills to allow that to go on. Again, it's not something I like, and the majority of our folks don't do it because we've examined and taken a hard look. Our Pharmacy and Therapeutics Committee has taken a hard look at that and said, the evidence just really isn't there, and so many of the studies that initially said that were positive had to be retracted. And that's like the ultimate slap, is when your studies have to be retracted in science. That means you did something wrong with your data. Antonios, your thoughts? Dr. Antonios.
Yeah, well, I agree, Dr. Stites, and we're just kind of confused about the value that the bill would bring to the practice of medicine, to the practice of pharmacy in the state. And there's other ways to be able to manage throughout the state the emerging medicines. There's always going to be medicines that will have to be evaluated. The evidence will have to be weighed by the professionals, and we want to just let the professionals do what the professionals do. I do, think that there is something that would be very helpful to our state as a whole, both at the state and the federal level. And something I mentioned earlier, and I think everybody alluded to, the scars that currently exist in that workforce in healthcare in general. It's in rural areas, it's in urban areas, and whatever can be done to support the workforce will help us become more resilient to tackle the next wave and the next variant, and it is of critical importance. We've been tracking very carefully and hyper-focused on the COVID-19 numbers, but we all know that as a nation, even when those numbers go down another 25%, 50, 100%, even if we're down to lowest ever numbers of COVID-19 here in 2022 and beyond, the workforce is not the same. The challenges of the workforce will persist. So it's important for people to know it's not only correlated with the COVID-19 numbers. There are long-term impacts that I think could be tackled in creative ways. And it's needed.
It sure is. Hawk, you had a comment?
Yeah, I'd just like to, again, piggyback on these great comments by our guests and you. We have always said we've been transparent. We try to provide you the most up-to-date information about our health system, about our hospital, but also be transparent about the evidence out there and the evidence basis for all of these decisions that are made, whether it's in diagnostics or treatment. We should state that, currently on the NIH treatment guidelines for COVID-19, also there are only really 5 drugs that are available for use in those patients that are not hospitalized, in those ambulatory or outpatients. And those are remdesivir, Paxlovid, sotrovimab, and molnupiravir, and then in special circumstances, that corticosteroid dexamethasone. So we are really trying to be consistent with this main body and with really the main bodies around the United States, including the FDA and the Infectious Disease Society of America, as well as the NIH. And so we are really trying to use that evidence-based medicine to support what we do as a health system when we do prescribe these drugs.
Yeah. Well, thank you to all the physicians at this conference. We know your time is valuable and appreciate your commitment to public health. Thank you to the media for sharing this crisis communication, and thanks to the community for watching, listening, and asking such thoughtful questions. Please share today's briefing with friends and family. We want you to know that we will gather this group again next Wednesday for one more assessment of where we are on this surge. We want you to stay safe. Please observe the pillars of infection prevention and control and get your boosters. Remember that COVID is the enemy, not each other. We're on this battle together as a community. Let me add this. 10 or 20 years from now, 5-10 years from now, people aren't going to remember Senate Bill 381. That's a bump. What they're going to remember is that family gathering that Dr. Long mentioned, in which 3 people died needlessly. They're going to remember the deaths that have occurred and affected us all needlessly. And not because these people were going to die anyway. They died of COVID. That's what we're going to remember. And we're going to be thinking, why didn't we take the choice to prevent this tragedy when that was an easy option? That's going to be the discussion we're going to be focusing on. And that's really what we should be focusing on every single day. The drugs that are recommended for COVID-19, like Paxlovid, have been clearly demonstrated to reduce hospitalizations by 85%. That's a drug worth talking about. Sotrovimab, the one monoclonal antibody that works for both Omicron and all the other variants, 85% reduction in hospitalization. That's a drug worth talking about. Losing 3 family members from a family gathering, that's a moment you'll always remember. Jess, what have you got for us tomorrow on the update?
Yes, Dr. Stites. Also, we're talking about the National Cancer Institute is now conducting a large study of people with cancer who also have COVID-19. They're trying to learn more about the risk factors to help doctors better manage cancer treatment and COVID at the same time. So the study is also going to look at genetic markers of serious illness from COVID in people who have cancer. So please join us, because Vice Chancellor and Director of the Cancer Center, Dr. Roy Jensen, is going to join us. And also Chair of Radiation Oncology, Dr. Ronald Chen, will be here. So please bring your questions, all your cancer questions. We will get those answered from our 2 great experts. And as we close, Dr. Stites, you had mentioned it, we are trying to keep people out of our emergency department, certainly during this weather. We know it poses serious health risks when it comes to heart attacks and frostbite. So here is some expert advice on why and how to avoid both of those risks. So please, everyone, stay safe today. We will see you tomorrow. Make it a great Wednesday.
Cold weather causes changes in our blood pressure. As we react to that exposure, it can affect our heart rate. It can also increase some of the tendency for inflammation in the blood vessels. That can also result in a clot in our coronary arteries, and that can result in an impairment of blood flow to the heart muscle and result in heart attacks.
Extreme cold can also injure the tissue. The tissues there start getting very cold, and when it gets exposed to cold for a long time, ice crystals start forming in the tissue. Blood vessels get slowed down or clamped down, and when tissue don't get oxygen for a long time, it will gradually die. Numbness and pain are the earliest signs.